Welcome, everyone, to the Top Minds podcast, where we bring you the best experts in healthcare and life and business. This is your host, Dr. Scott Gray. I'm the founder of several healthcare businesses, including Regenerative Health Centers of Florida and Gray Marketing Enterprises, where we help patients connect with the best doctors in the world. And actually, that's why we have our guest on today. We're going to introduce here in just a second. So we've connected over 100,000 patients to the best doctors out there and want to continue to do so. And this episode today is brought to you by GMEdigital.com. That's Gray Marketing Enterprises, where we completely run your healthcare marketing so that you can focus on treating your patients and doing the best job you can there. If you're interested in trying to find more of the best patients that you can help, reach out to us. Go to GMEdigital.com to learn more. So today I want to introduce Dr. Omar Pizano, who's with us today. He's a medical doctor in Tijuana, Mexico at CHIPSA Hospital. He's treated hundreds of cancer patients. He's been part of clinical trials, even getting a medical device, a breakthrough medical device, get some FDA love and breakthrough status there. And he heads up the stem cell program at CHIPSA, like I said, as well as treated hundreds of patients with cancer. Dr. Pizano, thank you so much for joining us today.
Well, you're very welcome. Thank you for having me and giving me the opportunity to explain a little bit more about the stem cells and how we can help people with them.
Awesome. Very good. So let's start a little bit, just kind of how you got started. And how did you end up at CHIPSA and, treating patients with cancer and now getting into the world of stem cells?
Okay. Well, yeah. Well, after I graduated medical school, I got into working at a regular hospital. In this hospital, you could see everything from pneumonias, pediatrics, pregnant women, everything, plastic surgery. So once we had this patient, she was 18 years old and she had lymphoma. Her lymphoma was very, very advanced. And one day she came into the hospital. She was really sick. She had an electrolyte imbalance. So we managed to get her stable and we called her oncologist. We asked for any directions that she had to give us. And she said, just give her painkillers and that's it. I'll be there later. Okay. We gave her painkillers. We thought that maybe she was going to do a different intervention. And when she got there, she just paid her a visit for like 15, 20 minutes. She left and she didn't say anything. We called her. So what are we going to do, doctor? And she said, well, nothing. Just give her painkillers, make her comfortable. She's going to die. And I was like, but she's only 18 years old. She's really, really young. And you could see her, despite she was 18 years old, she looked like a 14 or a 13-year-old because of the cancer. She didn't grow up properly. And well, yeah, that was like a shock to me. And eventually we managed to get her out of the hospital that time. But like a week later, I found out that she passed away in her home. And it was like disappointing to me that you just leave a little girl left to die just because, you weren't able to treat something else, or you weren't willing to treat something else. I mean, it was disappointing. It was disappointing. And a former colleague of mine that used to work with me at that hospital, he ended up working at CHIPSA because, destiny, whatever. And he called me once, hey, you want to come work with me? What do you do there? Well, we treat cancer patients, but we do it in an alternative way. So I said, yes, let's give it a try. I know that conventional medicine is not working properly, so might as well. And that's how I got here. And yeah, as a regular MD that they train you in the Western medicine, you are trained to distrust this type of therapies. But once you start seeing them in action and you firsthand experience and see how the patients evolve and how they improve, you know that what we're doing is something good and it's something different, and that someone else or everybody else, for that matter, should be doing.
So give us an idea of like a patient or two that have done well with the more, I know Ed and everyone there kind of likes to talk about is where conventional medicine meets alternative, where you don't just throw one out, but put them together to give the best possible treatment. What are some examples of maybe a couple patients that have done well with treatment?
Well, yeah. Well, we treat like basically every type of cancer except, unfortunately, acute leukemias and cancer in children or underage patients. But for example, the most common ones, breast cancer. I remember she was one of my first patients. She had breast cancer. She was stage 3B, almost 4. And we started doing all the conventional therapies that she was doing. She was at home taking Tyker, which is a lapatinib. It's a conventional. Now they call it chemo, like one of the modern chemos, but it's not chemo per se. But well, she was doing that, and we didn't tell her to stop it. On the contrary, it helps with what we do, like synergistic work together. We were doing plus low dose chemo with the IPT. We were doing the colis vaccine, all the ozone, the hyperbaric chamber. So when we started doing the colis, we started doing the colis straight into the tumor, which is, if you have access to the tumor, that's the ideal way to administer the colis. So we were doing it straight into the breast, into the tumor, and the breast got so big, got so red before it started to get better. The patients usually stay here for 3 weeks, and she ended up being here with us for almost 2 months because she was having really good results.
Yeah, and so that's where you use the colitoxin that goes in, and it basically increases the inflammation before it decreases it. Isn't that right?
Yes. Her tumor got so swollen that the skin started to open up, all the things started to go out. Unfortunately for her, it got infected. Apparently this bacteria that she contracted was resistant to certain antibiotics, so it got a little bit worse. She ended up going home, and back home in Seattle, her infection was more or so under control. Eventually, she ended up in the ICU. The doctors told her that she wasn't gonna leave beyond the ICU. When she managed to push through it, and when she got out, she went to the oncologist just for the checkup, and she ordered to do a PET scan, and the PET scan came back completely clear. I mean, you could see the tumor, but it was like a rock. It didn't grab any of the contrast of the PET scan. Tumor markers completely normal. So after that, she was in remission, and she's still in remission. And that was in 2017. That's almost 3 years ago. So on a stage 3B, there was practically a stage 4. The patient, she was really sad. I mean, she was 78 at that time. So usually with all elder patients, they don't want to do a lot because of the age. But now she's in remission. One of the success stories.
That's awesome, man. I mean, it's just so different from your guys' approach compared to the normal thing, and just like that story you shared earlier about the 18-year-old girl, man. I mean, that just breaks your heart hearing something like that, and I can see how I could definitely change your view on this and how we treat these things. And I'm sure not all doctors are like that, but at the same time, I just love what you guys are doing, and I know that you've been super successful with cancers in a way that we haven't been able to treat in the U.S. And now you guys are opening up the stem cell side of things, and obviously, in the U.S., it's much more limited to what we can do than what you guys can do, and that's what I want to get into because I have patients that will go into our clinics, and maybe they have an autoimmune or a different disease where I can't do anything about that, but you guys do those types of things. So let's dive into this like one step at a time. First of all, with stem cells, kind of go through the different types of stem cells that are out there and why and what cells you use and why you use the ones you guys do.
Yes. Well, we use stem cells mainly to treat autoimmune conditions. However, there are other conditions that create chronic inflammation. for example, a MRSA staph infection, it could be treated with stem cells to help decrease the chronic swelling and to make the staph more sensitive to the use of antibiotics. But going to the question that you asked me, there are several sources, like you said. You have bone marrow-derived mesenchymal stem cells. You have adipose tissue-derived mesenchymal stem cells. You have hematologous-derived stem cells, mesenchymal stem cells, or blood-derived. And lastly, you have umbilical cord-derived mesenchymal stem cells. We use umbilical cord-derived mesenchymal stem cells. But before I move on to that, the first three, bone marrow, adipose tissue, and blood, you can get them from the patient or you can get them from a donor. If you get them from the patient, first of all, it involves a surgical procedure to retrieve the bone marrow, to retrieve the blood, to retrieve the fatty tissue. Secondly, you'll have to send those cells to culture to expand, to expand further so you can have the product itself that you will administer to the patient. This process takes about 3 to 4 weeks, depending, and you need to have a specialized lab to do that and also to test for the special markers that will determine that if these cells that you grew are in fact stem cells. So you need to do that. Okay. And third, another disadvantage of doing that is that if the patient, for example, has lupus, is already in the genes of the stem cell to express lupus. So when you inject that into the patient, with all the signaling of the inflammatory environment, the stem cells will end up doing nothing, or even worse, they could transform into pro-inflammatory cells and worsen the condition even further. That's why I don't like doing stem cells from the same patient. And the other reason is that if the patient is 50 years old, the stem cells are 50 years old. So that means that their potential of replication and differentiation is way less in comparison to, for example, umbilical cord ones. That's the aspect if you do it from the patient. If you get stem cells like that, of those sources from a donor, you can get a healthy donor that won't have the lupus and all those genes. However, how old is a donor? Is a donor 50, 60, 40? The same issue. The stem cells are old in comparison to umbilical cords. Umbilical cord stem cells that we use, as the name says, they come from umbilical cords. These umbilical cords are obtained through donations then of healthy mothers that had healthy babies through natural vaginal births, not even C-sections. These umbilical cords are then processed in a lab in San Diego, California, under good manufacturing practices. So that way we ensure that we're having a top quality product to give to our patients. And with this, we know basically an umbilical cord is 0 days old. So the potential of differentiation and replication is way, way greater. And because the mother is healthy, the baby was healthy with a normal pregnancy, we know that there are no bad genes to carry on into the recipient of the stem cells.
Very good. So you said you obviously, and I'd not heard that before, being able to treat something like MRSA that could help with, that type of inflammation and also, even make it more, make the antibiotics more potent and effective. And I know you guys have treated a lot of RA. That's kind of been the big thing for you guys. Give me an example of, just kind of a case with RA that you guys have treated.
Well, we have the first patient that we had, she was a professional boxer. So for her, working out was really important. Still is.
Yeah.
So for the past 3 years or so, she wasn't able to hit the gym at all. She was able to teach classes, but she wasn't able to do any exercise on her own. Even walking for a mile was painful for her. And she was under Xeljanz at the moment that she got here, and she was also under leflunomide. And obviously, the RA not controlled. When she got here, we did a score. It's called DAS-28, developed by the American College of Rheumatology, that takes into account painful joints, swollen joints, and CRP, C-reactive protein results in the blood work. So the score that she had, it was equivalent to intense activity of the disease. She stayed here with us for 3 weeks. What we like to do is that we like to do treatments prior to the infusion of stem cells to prime the body, to prepare it, and then just do the stem cells, and then another couple of rounds after the infusion of the stem cells. So she was on her day 14 or 15, if I recall correctly. She didn't receive the stem cells yet. At this point, she was like, "Doctor, I feel great. I feel no pain. I feel like I can walk. I mean, I can do squats in her room." She was super happy, and she didn't receive the stem cells yet. She ended up having the stem cells. She went home. When she went home, we ran the DAS28 score again, and at that point, her DAS28 decreased to a moderate activity of the disease, but this is biased. Why? Because when we do colis, we create an inflammatory response on the patient's body, and this makes the CRP to shoot through the roof. So when she got here, her CRP was like 0.78, which was normal, and when she left, because of the colis that she was doing, her CRP was around 80. So that's more than 100 times elevation.
Right.
But that doesn't mean that it was real. That value was artificial because of the colis that she was receiving. And we managed to decrease the intensity to moderate just by by reducing the number of painful joints and the number of swollen joints. So imagine if this CRP was 0.78 as when she got here. That CRP, hypothetical CRP plus the physical improvement that she had was equivalent to a low activity of the disease, almost close to remission in just 3 weeks. And the stem cells start working their effects after between 3 to 5 weeks after they are infused. So at that point, it was the effect of only the priming treatments. Eventually, when she got home, all her symptoms went away completely. She had also been fighting with this problem of plantar fasciitis for a year and a half now, with no improvement due to the stem cells, and everything was great. 3 weeks after she was gone, she sent us an email. "Oh, doc, I was able to do my first pull-up for the first time in 3 years. I'm super happy. I'm able to train again. So this is my life. I miss this so much." She was one case. Another case, she came here with moderate activity of the disease. She stayed here for 2 weeks because her activity was less intense. And after 2 weeks, remission, complete remission. Even though, again, that her CRP was slightly elevated, it was around a 40. But when she got here, her CRP was about a 5, was elevated, but not that much. So even though with a high CRP, she was able to reach remission because she had no swollen joints and no painful joints. So her quality of life was improved greatly.
Wow, that's awesome. So does the C-reactive protein, does that go back down like within weeks, like after they go home? Does that go back down again, or how does that work with the coli?
About a month, and about all depends about a month, and depends on how intense the response to the colis was. If she was having only local responses, because when they go home, they do it subcutaneously. If she was only having local responses, it'll take about a month. If she's having systemic responses with the fever and all those things that the colis gives, probably about a month and a half or maybe 2.
Okay, yeah. So obviously RA, I mean, those are awesome stories and awesome examples. Are you guys thinking about or looking at other autoimmune disorders that you may start to treat or are looking to treat, anything like that?
Our main goal here is to treat RA, to treat lupus, to treat Hashimoto's disease, the thyroid disease, multiple sclerosis, and Crohn's disease and Sjogren's. Those are like the main ones. But yeah, I mean, we can expand this to psoriasis. We can expand this to vitiligo, pemphigus, which are skin disorders. And usually when you have a skin issue, you like to treat it right away. So yeah. Yeah,
and I could talk to you about this later. we had a patient with psoriasis that did stem cells, and it wasn't for that. It was actually for a joint issue, but their psoriasis just kind of disappeared. Very, very cool. So we can talk about that later. But I know you guys have like a scientific advisory board. Can you tell me a little bit about that? Like, who's on your scientific advisory board, and about your team?
Well, the scientific advisory board involves eventual consultations with Dr. Marancola. He's based in San Francisco, UCSF, if I recall correctly. That's the university where he works at. We also have Gar Ildebrand. He was a former director of one of the NIHs in the States a few years ago in the epidemiology. We have here in Mexico, Dr. Escobedo. He was the director of one of the biggest hospitals here in our city, in TJ, in government hospitals. He's a medical internist. We have a staff of 20 MDs that are treating physicians. We have a general surgeon. We have an oncological surgeon, and we are hopefully gonna get an oncologist, a medical oncologist in the future. But that's our staff. That's our scientific advisory board. And Dr. Marancola, sometimes when he can, he puts us in touch with one of his friends so we can get further advice.
Yeah, very good. Now, I know, have you guys talked with Dr. Thomas Ichum? Have you ever had any contact with him?
Well, yeah, actually, he's the one. Thank you. I forgot about him. Yeah, he's one of the pioneers in this area, and he's the one that is helping us develop this stem cell program. And he's the one that advises about using umbilical cord stem cells and how to use them, when to use them, even ways of administration. You can do it IV, you can do it into the joint, you can do it, for example, for MS, there's a possibility to do it epidurally, like for the pregnant ladies, intrathecally, you can do it that way. So he gives us those advices so we can start developing our protocols that are from CHIPSA.
Yeah, that's awesome, because I mean, he's kind of, for me, when, Ed told me that you guys had him working with you, in all my studies of stem cell, one of the first books I ever got was the big MSc book that him and Dr. Reardon put out with all the research of stem cells. So I just wanted to bring that up because I want people to realize the level of expertise you guys have behind you. And I mean, this is just a world-class group that you guys are doing, and everything you're doing. It's super exciting to see. So just as far as stem cells go, anything else that you would want to talk about as far as the stem cell therapy, and maybe how you guys see things different than other people doing stem cells, or anything else you want to share?
Yes, stem cells, we do, like I said a few minutes ago, priming treatments before the infusion of stem cells. Some trials, they suggest that when you inject stem cells, even though they are anti-inflammatory, when you inject them into a really pro-inflammatory environment, they receive all those signaling and they become pro-inflammatory. Instead of doing their job, they just transform into something that you want to get rid of. And all trials, they do the same thing. The patient has RA. Oh, give him 40 million cells and we'll see him within 1 month, and so on. And they just assess the evolution of patient throughout time, giving just one dose and with nothing else. And despite that they do that, in these clinical trials, they have demonstrated safety and they have demonstrated efficacy just by doing that, not even priming, not even repeating the dose. Certain trials, they do repeated doses, but the majority of them are just one dose, and we'll see how you evolve. So in order for us to maximize the chances of the patient having a really good response and having a long-lasting response, we do these priming treatments there are the treatments that are really similar to the ones that we already use with our cancer patients. The Gerson therapy, for example, is fundamental. We'll do intravenous infusions of vitamin C, intravenous ozone, the hyperbaric oxygen with a chamber. We'll do the Myers cocktail. We'll do the colis, it's also certainly really important. We'll do something called NADH. We try to attack the problem from its root and from several angles. To us, the goal is to normalize the function of the immune system so that way the immune system stop attacking the body of the patient, and therefore if there is no new attacks, there won't be any new swelling. If there's no swelling, there are no symptoms, long-lasting response, patient will be in remission. That's our goal. Not just giving the stem cells and give you the blessing and that's it. No, we'll try to approach it from several angles.
Yeah, that's awesome. So what does the process look like? I know that one of the things when I talked to Ed, and people can check out that other podcast that we did where he talked about how people can get a free call, with the doc. They could get on the phone with you and talk about stem cell and whatnot. So let's say someone talks to you. What does that process look like if somebody qualifies for stem cell? How does that start with you guys, and then how do they get down there? Like, what does that look like?
Well, usually patients, they either send their information and they receive a call from the call center, or they call the call center directly. And when they call, they're going to be asked basic questions: name, age, gender, your diagnosis, time of evolution, medications that you take, etc. Then they're going to be scheduling the call with me, and I'm going to be calling them time and date already scheduled. And I'm going to ask even more questions to try to determine if the patient is a candidate. If the patient is a candidate, I will proceed to explain more about the treatments and how do we work, all the logistics on how CHIPSA treats their patients. And eventually, they will be able to book a date to get here, and they will be receiving the treatments here at CHIPSA. Depending on the patient conditions, patients can stay either from 3 days, 1 week, all the way to 3 weeks or even more. Depends on the severity of the symptoms and the condition itself. But yes, once they reach out to us, I'll be calling them. I'm the only doctor in charge of doing the stem cell calls at this point, so I'll be calling them, and basically a more extensive Q&A, a little bit about their background, how did they get the diagnosis, how are they feeling at this point, and if they have tried any different treatments in the past related to stem cells, and if they have, what was their response, what type of stem cells they used, the dose that they used, so we know what we're dealing with beforehand. And obviously when the patient gets here, gets a physical assessment, gets blood work done, if imaging studies are required, they will be done. So we know, again, with scientific basis, what we're gonna do before do it.
Yeah, awesome. And it's real simple too, right? I mean, let's say someone's in Chicago, like basically they can fly down to San Diego, and then you guys kind of, set everything up so they can get down into Tijuana. To make it real simple like that. Okay.
Yeah. Just basically, my flight is November 10th. I arrive at 10 a.m. The driver will be there at 10 a.m. to pick you up and bring you all the way to CHIPSA.
Nice. Yeah, and I've been there, and it's real simple getting to the hospital, and it's an easy process, which I think is nice, because I think some of the medical tourism and things, going to other countries and whatnot, it's a little more difficult than just, going to San Diego. Driver's going to take you across right to the hospital and you're good to go. So I love your system, and I love what you're doing, Dr. Pizano. I mean, your depth of knowledge, and I think, a lot of that comes with your whole team and you guys working together. And I think it's like what you've done with cancer and all these other treatments, the ozone and the chole toxin and all these different things, put them together. I mean, it's like the ultimate healing protocol. And I just very impressed by it, and excited to see how it can help more and more people to hear more and more stories. And maybe we'll have to do like a follow-up down the road when you guys have, treated hundreds of people, more than you've already treated to get more and more cool stories. So thank you so much for taking time today. I really appreciate it. And we're going to put down in the show notes here a way that you can get in contact with CHIPSA if you'd like to talk with Dr. Pizano and learn more about what it is that they're doing, and get a consult with them, and see if this is something that may work for you to help you where you're at, and just see if it's something that could benefit you and your life. So thanks again, Doc, and we'll talk again soon. Okay.
You're welcome. Okay. See you.
Thanks.